Good afternoon. Welcome to the second annual APAPP National Conference. My name is Sara Rogers. I'm an infectious disease nurse practitioner.
And I am Jennifer Faber-Gerling, and I am a nurse practitioner with the Division of Mycobacterial and Respiratory Infections at National Jewish Health.
And we're going to discuss the pros and cons of treating non-tuberculosis mycobacterium. So, are you ready for a case?
Yes.
Okay. So we've got a 71-year-old female. She's got hypertension. She was diagnosed with bronchiectasis in 2023. She's got a productive cough, shortness of breath, fatigue, and about 5 to 10 pound weight loss. Her chest CT shows, of course, the nodular bronchiectatic findings in the right middle lobe and lingula. And her sputum cultures are growing 2 out of 3 with Mycobacterium avium. So you've made your diagnosis. What do you do now?
So that's a really good question, Sarah. So when I approach a patient in the clinical environment, when they meet the criteria, like you've just described in that case for treatment of mycobacteria, we approach the patient by looking at a lot of different factors. And I try to make it really collaborative with the patient because they have decisions to make, and it's my role to provide them with the information to help them make those decisions. Just because somebody is being diagnosed with mycobacteria doesn't necessarily mean that they have to be treated. There is NTM treatment guidelines out there that may help direct you as a provider. With those treatment guidelines, even if they meet the criteria, we can watchfully wait, or the term that I like to use is active surveillance. And we're not forgetting about this, but we're going to monitor them at different periods of time. I explain to patients how important it is if they have clinical changes to be getting back with me. And then our debate specifically looks at the pros and cons of treating those patients. And the criteria that needs to be assessed in those instances is kind of threefold or three-pronged. It's looking at the clinical presentation. You know, what kind of symptoms are the patients having? They're usually very vague. They usually have these symptoms for 2 or more years before they actually come to diagnosis. The radiographic findings, and not just evidence of disease, but evidence of progressive disease, such as bronchiectasis and the severity of that bronchiectasis. And then lastly, but not least, is the cultures and number of cultures. And we're going to talk a lot about, you know, ruling out transient cultures versus finding a pattern before we launch into treatment.
And one thing I want to add is that some of the things that people will be able to take away from our debate, besides the bloodbath of logic that we'll be going back and forth with, is a framework for treating non-tuberculosis mycobacterial infections. And you touched on some of them, the radiographic, the microbiologic and clinical findings. And ironically, that's the same criteria we use for diagnosis. I think that this will enable the pulmonary APP to be able to initiate referral sooner and know which patients need a referral or treatment right away versus those who could wait for a little bit.
Correct. And there also are, you know, while we use a lot of antimicrobial treatments, there are some non-antimicrobial treatments that can help be tools in this patient's toolbox to be able to maintain their airways. And that is mainly airway clearance. And there's a lot of techniques that the patient can use. And this isn't medicine. It's actually a modality that can keep their airways clean so that maybe we don't need to treat, or we can delay treatment.
Can you mention some of those?
Well, so there are different strategies. The main one is a APAPP device, which is an oscillating positive pressure expiratory device. We particularly like a aerobica device. It's a flutter device, and I explain to patients that it sort of rattles their cage. in combination with hypertonic saline. And there are different types of hypertonic saline. And this is a mucolytic that actually goes into the airways and starts breaking up sputum. It comes in 3%, 7%, and 10%. 10% is very irritating and can be utilized more so for sputum induction, not on a daily basis. We can also level up from that, and we can go to high frequency chest wall auscultation, which is usually in the form of a vest, which is a garment. And then lastly, the newest kid on the block is OLE, which is oscillating lung expansion, and like the Valera technology. And this is all very helpful. You know, it is hard to get a patient to embrace some of these things if they don't know that how important it is and why they're doing it. And it really is to decrease that bacterial load, keep things moving so things don't sit there and become more problematic later on.
It certainly has a lot less side effects than the therapy that is related to some of the antimicrobial treatments. What would some of the factors be that you would want to start someone right away? For instance, we could even go back to our patient, and maybe even talk about some of the things that she may or may not have, but just as a broader example.
Well, sometimes the pathogen itself may be more disease causing, and you might want to start quicker than that. The bacterial load, are they actually have smear positive or smear negative? How much bronchiectasis or underlying lung disease do they have? So the severity of the disease, is it cavity? Or is it more what we see as nodular bronchiectatic disease? So I think all of those factors, I mean, if they're all on the other end of that spectrum, you probably need to treat and be fairly aggressive with that treatment to prevent progression of disease.
And then some of the things I like to do is educate the person about what we're looking for so they can keep an eye out on how they're feeling. Additional weight loss. I know BMI is strongly associated with worse outcomes, less likely to not clear their cultures, and more likely to progress. What are some of the things that you tell folks in your practice in terms of when you're initiating, let's say, watchful waiting, maybe they're not ready yet? What do you do to get them to be involved in that?
Well, you definitely want to partner with the patient, and you want to explain that if they start having clinical changes, you need to hear from them. They need to submit a sputum culture at that time. It may be time to get a repeat CT scan to see the nature of their underlying disease. And I typically say if you have that change of symptom within a 48-hour period of time, get a sputum, see a provider, let us assess what needs to be done as far as treatment. Certainly, if they have significant changes like a hemoptysis episode or something like that, we just don't want to miss that window of opportunity to get them on treatment at that time.
Now, in terms of cultures, you mentioned smear positivity, and I know I'm asking for the right answer, of course, but what are some of the other MAC species that you would be concerned for? Like, for instance, our patient grew avium in 2 out of the 3 cultures. What if she grew intracellulare?
So the NTM treatment guidelines say that you have to have at least 2 sputum samples that are positive for mycobacteria. Now, the tricky part about MAC, for example, like our patient grew, it is a complex, and it is composed of 3 different types of organisms, intracellulare, avium, and chimera. So say you don't know what your lab is giving you. You don't know if it's subspeciated. Say they really actually came out as Mycobacterium avium, but they're really not that. One's avium, one's intracellulare, and one is subspecies chimera. They actually would not meet the treatment guidelines to actually be treated, because we're seeing transient organisms. Every time you collect a sputum, they're growing something different. We want to see a consistent organism to really push us to say, yes, this is real, and we need to start treatment.
So I'm hearing that partnering with your microbiology lab is definitely important, especially getting identification on a species or even a subspecies level. What other things do you look at in terms of radiographic characteristics?
Certainly progression of disease, because if infection is driving that, then we do want to be fairly aggressive in treating that. But, remembering that three-pronged approach, clinical presentation, radiographic findings and progression of disease, and then cultures. The treatment for these patients is a long duration, and I want to be fairly convinced that treatment is the right thing to do for them, because I'm not only exposing them to antimicrobial treatment that could cause symptoms, I'm also signing them up for access to a lot of clinical and healthcare day-to-day schedule, like follow-up appointments, blood work and monitoring, sputum culture expectoration, and running it through the lab. And if you have a young person who's working, we know how our day looks and how quickly it fills up, and it's sometimes hard to prioritize this. So I want to be, as a provider that would be recommending treatment, I want to be very convinced that this is the right thing to do. And all mycobacteria are slow growing, and so we have the tincture of time to be able to collect these data points to be able to help the patient make this decision moving forward. Certainly the patient has to be ready. They have to see this as a priority. They have to probably know that it's affecting their quality of life, because once they start, there's a huge commitment there.
And I wanted to add, in terms of quality of life, I know one of the things that I brought up on the clinical side is that there is not one aspect of life that is not affected by this infection. Certainly activity, but also social, occupational factors that go inside with the way people are feeling. The fatigue is real and it's bad. The weight loss is in a population that probably are not obese and never have been. So losing weight in someone with a BMI of 19 or 18 is frightening, very frightening.
And to some degree, that may be more important to address than actually treating the infection, is that there is a subset in medicine that we call treatable traits, and weight gain or weight restoration is certainly one of those factors for sure. The airway clearance, that's the foundation of care. And so sometimes just investing into those additional resources would be helpful for your patient and might prevent them the necessity for treatment.
Would you treat our patient? Would you initiate antimicrobial therapy?
I would not at this point in time. I would actually take that sort of active surveillance, and I'm not going to wait a long time. Usually that next CT follow-up would be 6 months. I'm going to be getting at least monthly or bi-monthly sputum cultures so that I'm on top of it if the bacterial load goes up. I'm going to be communicating with that patient and seeing them regularly or doing virtual appointments to be able to see what their symptoms are doing so that I don't miss that window and then have regrets that I didn't start them sooner rather than later.
Sure. So some of the things you can expect from our debate is a guidance on how to approach a patient who meets criteria for NTM pulmonary disease, how to approach this person in terms of surveillance, their risk for progression, and some helpful techniques in as far as treatable traits and things that you can do prior to initiating antimicrobial therapy. I think a lot of us think that, we've got an infection, treat it. Not necessarily appropriate in this space all the time.
Well, that's all that we have in regards to this topic, and I want to thank you for your attention. Hopefully, a lot more colleagues will join us at the APAPP conference in 2026.